Great. Well, hello and welcome to the Stanford Maternal and Child Health Research Seminar Series. We're coming to you virtually this time and because of the pandemic. And so thanks for joining us here. We are going to wait a few minutes while everyone jumps on to the seminar. But I just wanted to just welcome you and to say that the next few seminars will be virtual. I'm Tony Orr, one of the assistant director for the MCHRI, and have a wonderful set of education committee members that are really putting together these seminars. I wanted to just introduce a few slides. So today we're going to talk with Carlos Milla and Zach Sellers, but in 2 weeks we have. I hope you'll join us for the next seminar, which is Mike Schneider, who's the Asherman Professor and Chair of the Department of Genetics, who'll give us a wonderful and exhaustive demonstration of big data individual health, including a more recent set of publications about fitness and the molecular underpinnings of fitness. So please join us on June 15th. Sign up again for that, register for that seminar, then you'll get the Zoom link. The seminar series will take a break and then continue here in September with novel strategies for gender-based violence against adolescents, a very important topic, as we know, given the current situations. And so please join us on September 14th. In October, Desiree LeBeau will talk about the healthy planet and climate change. In November, we'll have our symposium. And then it'll continue with Melissa Bondi, the new chair of the Population Health Sciences. Will talk about pediatric adolescents. And then really for our virtual seminar in November, we really are excited about welcoming David Williams, who's the Chief Scientific Officer of Boston Children's Hospital, who will join us for our virtual symposium November 6th. So we'll be looking for that. But today, and then here's our education committee. If you'd like to join us or give us suggestions, please send them to any of the members of our committee who will love to talk to you more about our programming. And then finally, we appreciate you completing the online survey form with suggestions, helpful hints that will be sent to you shortly after the talk. Anyway, but today we're really excited about Carlos Milla and Zach Sellers talking about cystic fibrosis as a paradigm for precision medicine. Carlos is a professor of pediatrics at Packard Hospital, with a long history on research on inflammatory responses that lead to airway disease and CF. CF really is a central program in our Packard Hospital, and Carlos is really one of the leaders in understanding and treating these kids. He will talk about early detection of lung disease and how the precision medicine for the mutations really leads to understanding how to treat them. And that'll be followed up by Zach Sellers, who's a new instructor now about 2 years, whereas that lab is open in gastroenterology. We'll talk more about the precision medicine part and bicarbonate transport, as well as the gene therapy program that they're talking about. And so Carlos will begin, and then they'll be followed by Zach. Please note there's a question and answer Q&A button at the bottom of the Zoom. Please go ahead and submit your questions during the talk. And at the end, we'll have a Q&A session with both Carlos and Zach. And so with that, I'll give it over to Carlos to start the seminar. Carlos?
There we go. Great. Thank you, Tony. I really appreciate the opportunity, and particularly I want to thank CHRI for allowing me to come and give you an update of what I consider now a very rapidly evolving field, which is how we're dealing with patients with cystic fibrosis. And I think we're really trailblazing when it comes to how to think about genetic-based disorders. So just as a quick introduction for those of you who are not familiar or haven't heard about cystic fibrosis recently, is still one of the most common inherited life-shortening conditions. We know it's a multisystemic disorder, meaning it affects many organ systems. And the common denominator is defective ion transport across mucosal surfaces, being the most problematic in the respiratory tract. The US incidence is recognized as being fairly high at 1 in 3,500 live births, with a fairly high carrier rate also. 1 in 25 people is an unknown carrier of the disease. But we also need to very much keep in mind that it occurs across all ethnic groups with lower incidence, but still there's a fair prevalence of cystic fibrosis in every ethnic group. And that we see here in California, particularly with our Latino, Hispanic population and our Asian populations. So although it's always remembered as a disease that affects primarily whites of European ascent, we do see it with fair incidence in all ethnic groups. And this we've come to learn through universal newborn screening. Since 2010 in the US, newborn screening for cystic fibrosis has been in effect, and that has allowed us to be able to detect the disease in its early stages, shortly after birth, and is also available through prenatal screening. So nowadays, we're learning a lot about cystic fibrosis, starting just with the epidemiology, thanks to these screening strategies. But cystic fibrosis is known primarily for its main manifestation and the one that introduces the most morbidity, which is pulmonary disease, and this is a chronic inflammatory process with chronic infection. Now, what is the good news and also the fairly, what I can call a dramatic experience with cystic fibrosis is how we've been able to make very important strides when it comes to extending the life expectancy and also the prognosis for people diagnosed with cystic fibrosis. And I want to say that in the 2000s is, if anything, an expectation that children born with cystic fibrosis will be able to reach adulthood and lead very productive lives as adults. Nowadays, over half of, and this is a hallmark real development that occurred just a few years ago when the number of adults with fibrosis in the US surpassed the number of pediatric patients with cystic fibrosis. So now over half of the cystic fibrosis patient population in North America is of adult age. And the median life expectancy as of 2019 has increased to 47 years. Now, as I mentioned early on, there's a defect in ion transport across mucosa, and it's primarily a defect in transport of anions, with the most important one being chloride. And that's how cystic fibrosis has been known as a disease, but also from a not just biologic, but diagnostic perspective, is detecting a defect in chloride transport, what identifies people with cystic fibrosis, and is what we use in the clinic through the sweat chloride test. And here we're seeing that in a healthy individual, if we are able to get a mucosal sample, we'll be able to see upward deflection in short-circuit currents, which reflect primarily movement of chloride. And if we use an inhibitor of the CF protein, we'll see a rapid drop on that chloride current. In a person with cystic fibrosis, which is the lower panel, we are not able to introduce this change in current, which simply reflects the absence of any transport of chloride primarily. Now, the gene was associated with cystic fibrosis was cloned in 1989, and that brought a lot of hope and promise of being able to not just understand the reasons behind cystic fibrosis as a disease, but also identify a potential cure through what was proposed as potential gene therapy. It's a very large gene that codes for a fairly large protein, which has 1,480 amino acids. And as you can see in the lower panel of the cartoon, it's a fairly complicated structure of this protein with a number of portions of it that go across the membrane. And the structure suggests a chloride channel, which will go along with the biology known up until that time of it being involved in chloride transport. Now, what is important is that if you push fast forward to the 2000s, now we come to recognize that the genetics of CF are complex. It's a monogenic disorder, but there are thousands of different gene changes that we call mutations because they're associated with disease. And what that tells us is that there's a tremendous variability and complexity in the genetics from an epidemiologic perspective. But what is also important to keep in mind is that the deletion of phenylalanine at position 508 is the most common mutation seen across all populations worldwide, with North America having about half of patients carrying 2 copies, being homozygote for this deletion, and close to an additional 40% having at least 1 copy of this mutation. So close to 90% of patients in the US have at least 1 copy of this mutation. Now, to try to make our understanding of the different mutations that patients can present somewhat better organized, particularly to try to understand prognosis in the clinic, we can divide these different mutations into 2 major categories, what we call minimal or no function mutations, which will be associated with more severe dysfunction, and what we call partial function mutations, where the defect is not completely eliminating protein function. And this correlates fairly well with what we see in the clinic, meaning it's a good prognostic marker to be able to fully define if a mutation the patient carries confers partial function or absolute loss of function. And the delta F mutation, we know is a severe mutation because it affects protein folding. After the protein is made, it has to go through a number of steps to be processed and particularly folded correctly and eventually reach the apical surface of the cell and affect its function as a chloride channel. And what you can see on the cartoon is that the delta F defect, which is the red dot, basically disrupts the ability of a protein to be properly folded and traffic to the cell surface. So there's absence of a functional protein on the cell surface. Now, a really interesting observation not too long after the discovery of the gene was that this defect in processing of the F508 protein mutation was amenable to some level of rescue of the protein with manipulation in the lab, culturing the cells at low temperature. So that gives us some clues as to maybe this defect is not really, let's say, a completely disruption of a protein and with negation of any potential rescue function, but it might be amenable to some level of restoration, what we now call correction. Professor Copiro here at Stanford followed up on this observation, shown with small molecules, and here we're showing just with glycerol in vitro, you could also affect some level of restoration of protein function. It certainly created a lot of excitement and opened what we now call a three-pronged approach to how we're going to try to correct the CF defect to enact a clinical response in the patients. And this really was this sort of master plan was laid out in the early 90s, where instead of thinking about just one approach to try to address the problem that CF patients were presenting, to try different approaches and to eventually have at least one that will translate into an effective therapy in the clinic. And obviously, the first one was to try to look for ways of correcting the gene defect, and this nowadays is still being pursued as a potential for gene therapy. The second one, and this based on the 2 observations I just mentioned, was to try to discover therapeutic agents that will either bring some level of function to the defective protein or try to completely correct that defect in the protein. And the last one, in trying to find alternative pathways to CFTR. We know that there are many different proteins in the epithelial surface that affect also some level of ion channel function. And this led to tremendous research in trying to better understand channel physiology in the respiratory epithelium particularly. Now, eventually, it was the one in the middle, the one that was able to move the farthest along. And this was mostly facilitated through, in the late 90s, the development of high-throughput screening technologies. What this entailed was, first of all, having the ability to have a cell-based system with a reporter assay, meaning something that will tell us that the cells have recovered the chloride channel function. which is what we're showing at the bottom panel. You know, thanks to fluorescent probes, the green light was truly a green light, that we have found a molecule that was able to restore some level of chloride channel. So with this assay on hand, very large libraries of chemical compounds, over 2 million of them were put through the screening system, and that led to the identification of over 25 different categories of molecules that could be moved on then to try to see if any of these could eventually become a therapeutic. Eventually, this led to the discovery of Ivacaftor, the identification of what used to be called BX770, and this is now in the clinic under the brand name of Kalydeco, that was identified by Vertex Pharmaceuticals. And basically what this small molecule does is, if there's any protein present in the cell surface, it will activate it by keeping CFTR open for a longer period of time and then allowing chloride transport. And this will apply particularly for what we call mutations of the class 3, meaning where there's no gating, meaning no opening of the channel, or for the partial function mutations where we know there's some protein presence, but it doesn't have full function. Eventually, this was moved to the clinic, and this study now is really an old study, believe it or not. This has been out there now for more than close to 10 years. And the most remarkable finding of this study was really, number one, the very rapid onset of action. And here we're looking at changes in pulmonary function. The FEV1 is one of the parameters that we use to assess the lung function in patients with CF. And this showed that just after 2 weeks of treatment, there was a 10-point increase in the lung function of these patients. And the second real remarkable finding, particularly from my perspective as a CF clinical provider, is that that effect was sustained over the following year. And we had never seen something like that in CF, when you're able to introduce an important change in lung function and having that long-term sustainability of effect. Now, in parallel to this, there were obviously very strong efforts trying to target the delta F mutation, the deletion of phenylalanine, since again, this will really be a potential therapeutic for close to 90% of all patients with CF, at least in the US. And there were a number of molecules that emerged as potential candidates, with the drug Lumacaftor being the first one that was moved to the clinic. This was a real landmark study in CF, starting with the fact that we had hundreds of patients across the world that participated on these studies. This became a major collaborative effort between North America and Europe. What this study did, after testing 2 different drugs, is that we could introduce important changes on the FEV1, the same parameter that I showed before for the drug Ivacaftor, but they were of lower magnitude and somewhat weak compared to what we had seen with Ivacaftor. In some way, this was expected because, again, with the delta F defect, you have a major issue with protein folding, so there's very little protein that is really amenable to targeting in the sense of activating the chloride channel function. But that effect was sustained over time. And there were other parameters like weight and also a number of exacerbations and symptoms that also show mild and sustained effects. So that led to the approval and movement into the clinic with this drug. Now, we certainly were not fully satisfied with having drugs that only had mild effects, and the high throughput assay machinery kept going in trying to identify additional molecules. It's what it was called the next generation approach. And you know, the interesting thing is that this was moving pretty much at the same time that we were already moving these other drugs to the clinic. So it was like there was no real slowdown in the identification and movement to the clinic of novel compounds. And the idea with this next generation of correctors was to look at them in combination with the drugs we already had in the clinic to see if we can really push up to the max the rescue of that misfolded delta 508 protein. And again, the goal was to try to achieve a high enough level of restoration of function so that whether the patient had 1 or 2 copies of this mutation, we could get the same level of clinical benefit. And here just cartoons showing, that these are small molecules, which is important because that also allows for being able to rapidly scale up the availability of these drugs. And indeed, the clinical trials were very rewarding. This is the first study that was done in people with only one copy of the delta F508 mutation, meaning the heterozygotes. And what it showed on the left-hand panel is their changes in sweat chloride, which basically move from what will be called unquestionably diagnostic for CF and to the blue line, which is what we will call borderline for CF. So that told us that there was a very strong biologic effect that was sustained over time because this was a 6-month study. And then on the right-hand panel, what you're looking at is the pulmonary function using the same FEV1 parameter, and this show a very rapid and then sustained effect on the lung function. And the results in the people that have 2 copies, meaning the homozygotes for the F508 mutation, showed the same effect, where there was a decrease in their sweat chloride, and parallel to that, we saw a very significant improvement in their lung function. Now, obviously, what I'm showing on all of these graphs is the average response in on the patient populations that were treated. But one important point, and this is always what is on the fine print, is that, there were patients on both studies that were treated with the drugs that either had no effect at all, and some of them even worse than being on the drug. Certainly at a much lower proportion than the ones that received placebo, but that will tell us that there's an individual response that is going to play into what you see in terms of the clinical response at the individual level. Now, going back to then, what we know from a biologic perspective is that there are a number of mutations that are going to have an effect on the CFTR function. And these mutations are amenable to evaluation through in vitro type studies, which are the same type of studies that led through high-throughput screening to the identification of these drugs. But the important thing is that that in vitro testing has now been used more and more, and CF, I think, has led the way on this, to be able to get the FDA to grant extensions on the label for a given indication. And again, the first example of this was with the drug Calideco, where with the recognition and demonstration that we have a good and valid in vitro testing, that could be used to then move the drug to the clinic. So now this has become an accepted, and this just came out 2 years ago. Now we know that also the in vitro responses, and this is one of many examples that have been accumulated over the past few years, will also help predict and correlate with what we see in the clinic. And what we're showing here is how the measurement of those chloride currents I was showing before in vitro tissue preparations to correlate with what we see in the clinic in terms of lung function, for example. So we have taken on these observations to establish our own program here at Stanford, and here I've been collaborating. This is what I'm showing here is collaboration with the Allele lab at Stanford. We have a funded program to look at expansion of nasal cells as one way of testing for CFTR function, and not just that, but our main goal with this study is to try to identify other ways in which you can improve the overall respiratory health function. With this, we have established, and this in collaboration with the Wine and Copito labs here at Stanford, what we call now a sort of assessment platform, or what I like to call an assembly line, where we get biopsies from patients, and these are minimal invasive nasal brushings really, and then we can propagate the precursor cells and then differentiate them and do a number of measurements to try to not only understand the defects at the patient level, at the individual patient level, but also how we can correct those defects with the use of the different drugs that are in the clinic or coming to the clinic. And here I'll show you just a quick example of a patient that has a combination of 2 very rare mutations of very low frequency. So just mentioning the mutation can by itself identify the individual. And what we're showing is that yes, we can now very easily, though it does take a lot of work, isolate their progenitor cells, what you call the stem cells in the airway, which are known as basal cells. then pushed into differentiation to what we see in a respiratory epithelium. And here I'm showing how we can very nicely differentiate them into ciliated cells, which are the ones that look like a hairy cell, and mucus-secreting cells. So it's more, again, reflective of what the respiratory mucosa would look like. And then we treat them, for example, with the drug Tezacaftor for 48 hours, and we proceed to functional assessments, including the famous chloride current measurement. And here we're showing that these cells did respond, not with the same magnitude that we see on a healthy controlled cell, but we can introduce some important changes that tells us that there's been restoration of function. Then we're able to get this patient approved for the drug, and we notice a decrease in sweat chloride, gains in weight, and particularly in BMI percentile, which is a very important parameter in pediatric CF patients. And nicely, in parallel to this, also important gains in lung function. Now, some of this work, particularly chloride currents, has been done in collaboration with Zach's lab, which I'd like to introduce now for the next part of the talk. Zach has been a long-term collaborator, and now he's an instructor in our division of pediatric gastroenterology, and he's very focused on cell physiology, and particularly when it comes to epithelial ion channels. Zach?
All right, thank you, Carlos, for that introduction. And thank you to Tony and MCHRI for the opportunity to share some of the work that Carlos and I are doing together and across the CF Center as a whole. And so when we think about precision medicine for cystic fibrosis, I think there are several opportunities and challenges for us. And I've listed a few here that I'm going to talk about today. The first is accurate diagnosis. So Carlos mentioned that we've been able to identify now over 2,000 mutations in the CFTR gene. This is both an opportunity to understand how genetics plays a role in CF and CFTR function, but it's also a challenge because we need to then be able to parse out which of these mutations are pathogenic and which ones are benign. And that's not an easy task given the magnitude of these mutations. Also, I'll talk about this a little bit more, but CFTR as a protein is really an anion channel. So Carlos talked about its ability to transport chloride, and that's its most well-known ability, but it also conducts bicarbonates. And I'll talk a little bit about why that's important, and hopefully you'll be able to appreciate why this has been a focus of our laboratory. So beyond the diagnosis, it's important to also be able to predict what types of complications our CF patients may develop. We start seeing them in pediatrics very early now, thanks to newborn screening. And so we want to be able to prevent problems that they may have in the future. And most people think of CF as a lung disease, and certainly that still accounts for the highest amount of mortality in CF. But CF really is a whole body disease affecting many organs throughout the body. Outside of the lungs, the most notable system is the gastrointestinal tract, but really many organs are affected. So this can be a challenge to figure out how these organs may be affected, and it can be different in different individuals. So for example, one CF patient may have predominantly lung disease with very little GI disease, and another patient may have the converse, very little lung disease and very prominent GI disease. And then of course, what we want to be able to do is to be able to identify patient-specific drug regimens that will help these patients. We are fortunate now to have a number of drugs that have been approved and are on the market to improve CFTR function. And that list is growing rapidly. There are a lot of drugs that are in the pipeline to be studied, but these drugs are expensive, and we don't want to have to go through many weeks and many months of trials with these patients to see what's going to help them. And while these clinical trials have been especially useful, the endpoints are limited, so we don't know how these drugs will affect each of these different organ systems. So in speaking about diagnosis of CF, I think most people are familiar with the sweat chloride test, which I have listed as the macroduct sweat test here. But there are additional tests mostly used in research that also measure sweat gland function, and that can measure either the sweat chloride secretory rate from a number of different sweat glands, or even from individual sweat glands, as I'm showing here with the bubble assay that was developed by Jeff Line here at Stanford. There's also the nasal potential difference that can measure the voltage across the nasal tissue in situ here in patients. And then we can also use intestinal biopsies to either measure the current across those biopsies using the Using chamber and voltage clamp system, in which we can measure CFTR dependent current, or more recently, we can use those biopsies to make organoids. And it was discovered that these organoids will swell when CFTR is activated through the indirect movement of water as it follows the chloride transport into the organoids. So we now have a variety of different tools to measure CFTR function and help make diagnoses. But one of the things that all of these tools have in common that's also maybe their downfall is they all rely on chloride transport. And so none of them actually assess the ability for CFTR to conduct bicarbonates. And why is that important? Well, as I mentioned, CFTR can conduct both chloride and bicarbonate. We're still trying to understand how that occurs. Certainly there's tissue specificity depending on the function of the organ and the tissue, that it will preferentially conduct chloride versus bicarbonate or vice versa. But there was a nice study that came out by LaRouche et al. In 2014 that looked at a variety of mutations that in CFTR that were affecting those individuals that had pancreatitis. And so I'm showing two graphs here. On the top is looking at chloride current, and the bottom is bicarbonate current, both through CFTR. And you can see on the top with the mutations that are listed, most of those have no effect on chloride current, with the exception of the R117H mutation. In converse, when you look at the bicarbonate transport, almost all of these listed affect bicarbonate transport. And there are some, like the R117H, that affect both chloride and bicarbonate, but there are others that affect predominantly bicarbonate, but no chloride. So the real question is, well, how can we measure these defects if all we're doing is measuring changes in chloride transport with the methods that I showed you previously? Well, why is bicarbonate important at all in CF? Well, we've come to learn over the last number of years that bicarbonate is important in the mucus formation and expansion. And I'm showing here a diagram of a schematic put forward by Paul Quinton, in which they showed that the bicarbonate ions actually are important in the rapid expansion of mucins as they're released. And without bicarbonate, these mucins remain very compact. And below you're seeing clinical examples of that, where we have in the airway this thick viscous mucus that is blocks the airways. And in the intestine here, you can see these yellow strands are the adherent mucus to the bowel wall, even after extensive bowel prep. And we've learned through studies in the laboratory that if you increase the pH, that the viscosity goes down. And we've also been able to identify that if you replace this with bicarbonate, then you can increase the bacterial killing that occurs in the airway. And so really the pH of the airway really is an important part in the physiology and pathophysiology in CF. Now, bicarbonate secretion is especially important in the intestines, as its intestinal and pancreatic bicarbonate secretion neutralize the acidic stomach contents. And so what you see here is a trace from a pH pill study. So this is a capsule that's swallowed and measures the pH across as it travels along the gastrointestinal tract. And the dark squares is from a non-CF control subject, where you have a quick neutralization in the pH as the capsule goes from the stomach into the proximal intestine, and it maintains that pH, which is necessary for the pancreatic enzymes to work. In contrast, in the lower trace is from a CF patient, in which you see that not only is the pH more acidic, but it also takes a much longer time to achieve neutralization. And that's because of the impaired intestinal and pancreatic bicarbonate secretion in CF patients. So in my laboratory, as Carlos had mentioned, that our focus is on epithelial ion transport and signaling. And we primarily focus on two diseases, both cystic fibrosis and pancreatitis, with cystic fibrosis accounting for the majority of our work. And really, one of our fortes or expertise is in measurement of bicarbonate secretion. We're able to simultaneously measure both chloride and bicarbonate secretion. And so we've been doing that in the test-in, and then also have partnered with Carlos and others to do this for the airway. And so this was the workflow that Carlos had put forward from his lab, and together we've worked to expand this workflow to not only obtain nasal brushings, but also intestinal biopsies for people that are undergoing endoscopies. And then also to not only use short circuit current to measure chloride movement, but also to measure bicarbonate secretion as well. And so we started to do this utilizing intestinal organoids. We partnered up with Calvin Quo's lab here on campus, who has extensive expertise in organoid technology. And so what we do is we obtain endoscopic biopsies from people already undergoing endoscopies for their routine clinical health, and we get a few extra pieces for research purposes. We're able to take those biopsies and isolate the crypts, which have the self-renewing stem cells in them, and then we can culture them as organoids, as you see in the bottom panel there. They're initially as spheroids, and then they will have these outpouchings that will grow over time. Now, we know that in the intestine, there are actually many different cell types that exist along the crypt-villus axis. And what has been discovered is that by using different formulations of media, we can actually drive these organoids to recapitulate different parts of this crypt-villus axis. And so what we've done is we've taken that technology and generated both undifferentiated and differentiated enteroids that represent both crypts and villi, respectively. And then we can use things like qPCR to look at the expression of bicarbonate transporters, and also use a combination of functional experimentation to measure both chloride and bicarbonate transport across the monolayers of cells. And so to do this, we've actually combined 3 different technologies. One is the voltage clamp, in which we can measure the short circuit current or the electrical activity across the cells. We use Using chambers, which allow us to provide different solutions and different drugs in different sides of the apical versus basolateral side of the cell monolayer or tissues. And then we use something called pH stat, which allows us to measure bicarbonate secretion by titrating very small amounts of an acid. And so we can measure the bicarbonate secretory rate over time. So one of the things that we and others first wanted to learn was where are the acid-base transporters within the crypt-villus axis? And I'm showing you some data from our lab that is similar to what other people have also shown recently, in that there are some transporters such as NHE3, which is a sodium hydrogen exchanger, and this DRA, chloride bicarbonate exchanger, that are preferentially expressed in the villus tips. However, there are other bicarbonate transporters such as CFTR and this PAT1 chloride bicarbonate exchanger that are expressed in the villus tips, but also are expressed in the crypt region as well. And so what it looks like is occurring is that these crypt regions are really set up for chloride secretion. And the villus tips are really for bicarbonate secretion. And I'm just showing the different transporters that are expressed relative to each other. And so the intestine is really creating the sort of different domains in which they can secrete different anions. And you'll note that CFTR is expressed in both the crypts and in the villi. And so we can use this technology and these tools to measure how CFTR-mediated chloride and bicarbonate secretion are regulated and impacted by CFTR mutations. So what we've done is taken all of these things that I've shown you, and then we generate data that looks like this. And so the graph on the left where it says ISC, that's our short circuit current, which is the movement of ions across the membrane. And the way we do this, as Carlos explained, is that this primarily represents chloride secretion. And in these studies, we use a forskolin, which increases cyclic AMP in the cell and activates CFTR. And so you can see when we do that in undifferentiated or crypt organoids, you see this rapid increase in chloride secretion that then becomes sustained at a lower level. In contrast, in our villus differentiated organoids, we see very little increase in chloride secretion. And that's represented in the bar graph below. Now, when we look at bicarbonate secretion, we see that, and this is a trace actually from differentiated organoids, that we have a stable baseline secretory rate, but as soon as we activate CFTR through forskolin, that rate increases. And interestingly, that bicarbonate secretory response primarily occurs in the differentiated villus region, not in the crypts. And so these tools really allow us to measure the movement of both of these anions in the same cells at the same time. And we can use different regions of the intestine to look at that. And so really what we've done is modified this workflow, is where we will start out with a patient where we know a genetic mutation, and then we can obtain the nasal brushings, as Carlos explained. We can, if they're going for endoscopy, we can also get biopsies from that. We can also do rectal biopsies, which is less invasive. We do that in newborn infants routinely, and then generate different cells and organoids from the basal and stem cells. And we can also generate these monolayers to measure CFTR function, both chloride and bicarbonate. Or we can also look at CFTR protein expression and localization. And we can do that in its sort of basal native state, or we can do that when we've put on different drug therapies to screen as to whether these patients will be responsive to these drugs. And so what this really allows us to do then is we think we can improve our diagnostic accuracy by measuring both chloride and bicarbonate secretion, and to be able to have a bicarbonate assay that would complement all of those chloride secretory assays that I described earlier. By not just looking at the nasal airway or the lungs, but also the intestines, we think we can do a better job of predicting potential complications. And we also are able to see how different drugs may affect different organ systems as well. Go ahead, Carlos. You're on mute.
Thank you, Zach. That was very exciting. So from what you can see, certainly we've made a lot of progress when it comes to cystic fibrosis. And that just with having what we call nowadays symptomatic type treatments, things that will help us deal with the consequences, but not with the roots of the problem. Now, with the addition over the last decade of these newer, what we call modulator type treatments, we've certainly been introducing very important changes on to start just the quality of life of our patients, as well as get a better feel for what it means to have a disease-modifying agent for the management of CF. However, we hope that we can continue to expand on the patients that we can treat with these very novel treatments, and continue to make advances on the introduction of treatments that will give us even stronger responses. So I hope we're also leaving you with the view that, you know, we have very strong translational efforts that are very focused on the individual level. We're not thinking about treating groups anymore. We're thinking about how we can effect the most effective interventions at the individual level, and not just to better define the type of defects that patients carry, but also what are going to be the interventions with drug therapy that are going to lead to the, if possible, full restoration of function. Obviously, I had to close by thanking all of our funding sources, which are multiple. It really takes a village to do this type of work. And as you can see, we overlap quite a bit with Zach, but I have to really give a shout out to MCHRI, who really has been very supportive and has had a lot of faith on what we do. A lot of the bigger players who were able to get funding from them was thanks to seed funds that we got from CHRI. And most of the work that I'm showing from my lab really in one way or another has been supported at some point by CHRI, as well as the SPARK program at Stanford. And lastly, I really have to, I'll be remiss not to recognize that, you know, the work that happens on the front lines, I'm not there day to day. We have a lot of people and a wonderful team that are in direct contact with the patients and help us really carry all this translational work. So thank you, and I'll turn it back to you, Tony.
Great. Thank you so much, Carlos and Zach, for an amazing demonstration of, I think, two things. One, the team effort at Stanford, multidisciplinary team effort, both translational and basic, as well as really leading the way for precision medicine. I think it really is a model program for how to do it. And so we just want to congratulate you for a great talk. If anyone else also just has any questions and answers, please put them on to the list. And so a question from someone you know well, Jeff Wine. Do either of you have ideas about the different responses seen with Trikafta with patients having the same mutation?
Yes, that is an excellent question. And certainly there's a lot of work ongoing. Unfortunately, you know, COVID has put a little bit of a slowdown on this, but as these different drugs have been rolling out to the clinic, we've certainly been very interested to see, number one, if you know every single patient is going to show the same type of effect, and certainly we're not seeing every patient showing the same effect. And number two, we're trying to understand why it is that some people have stronger responses than others. Some of it may have to do with environmental factors and starting with whether the patients are really taking the drugs the way they're supposed to. But I think, and there are a number of us that are really on this in trying to understand what other potential gene modifiers are playing a role into all this.
And just to follow up that question, so are the drugs that are currently available, do they also affect bicarbonate? How many of them that were screened for chloride also affect bicarbonate secretion?
Yeah, I'll try and answer that one. You know, the answer is we really don't know, because everyone has been focused on measurements that focus on chloride secretion, not only in our clinical tests, but all the high throughput tests, and now that there's a lot more tests being done with the organoid swelling, which also utilizes chloride movement. So one of the things we've been trying to do in developing these tools is then to go back to these different mutations and see how is bicarbonate affected by these mutations. And then also, as we give these different drugs that we mentioned, do they affect chloride and bicarbonate equally? And do some drugs affect bicarbonate more than chloride and vice versa? So work is ongoing.
Yeah, that'll be very interesting for the pharmaceutical companies especially. One question about sort of phenotype-genotype correlation from Vishnu Shankar, and that's, you mentioned that the mutations can be categorized into one of 6 classes. How many of the greater than 2,000 CFTR mutations can be accurately assigned? And then another question sort of followed up from others is, how well at birth can you predict the life course based on these mutations and classifications for an individual kid that was diagnosed around birth? How good is it? How good are you guys in precision medicine to date?
Oh, there we go. Yeah, no, those are excellent questions. You know, I think it's a combination of questions. So you can really set your career in trying to answer those specific questions in terms of the genotype-phenotype correlations. As I mentioned early on, you know, the genetics of CF complex because of so many different mutations that we find in patients. And right now, we're probably getting just close to 20% of these mutations having fully characterized in terms of what they do at the cellular level. And obviously with the most common ones, the most frequent ones being the ones on which we know the most, which includes also the ones who are in the laboratories being investigated for drug effects. Now, what we also know at the individual level is that even if you have well characterized the mutation, and you take 2 people with exactly the same mutation, you may not necessarily see the exact same phenotype. So there's a lot of variability at the individual level that is probably impacted by what else is on the genetic makeup, as well as what other factors like environmental and socioeconomic are playing into it. What we know for sure is that at least just understanding whether a mutation is severely disruptive or leading to partial function can help us give some sort of a prognostication as to how someone can do from the very first few weeks of life, which is when the diagnosis of CF is happening nowadays, primarily through newborn screening.
That's great. Another question is, Dr. Sellers mentioned different formulations respond to different cells in the gut assay. Can you say a little bit about formulation of drugs and their effects?
Yeah, so as I mentioned, we're looking to see if any of the main CFTR modulators affect bicarbonate or chloride differently. But in addition to that, we're using these tools to screen other drugs to see if drugs that we haven't been using for CF could be of use in both in targeting the restoration of bicarbonate secretion through CFTR, but also another big interest in my laboratory is investigating non-CFTR mediated bicarbonate transport and how we can utilize drugs that increase bicarbonate transport through other transporters and use them in synergy with these CFTR modulators. So that work is ongoing, and we have some candidates that we're looking at. So we're excited about those.
That's awesome. Another question is, has to do with more of a therapy question, which is after your diagnosis, there's a delay from the actual diagnosis to when you actually can do these companion assays like gut organoids. How long, like in a practical sense, does it take to do these other organoid type analyses, and how do you treat the patient in the meantime? What do you do while you're waiting for the kind of phenotypic results?
We can get started on that, and particularly for the newborn screen question, I think is what this will allow. Like if we have a baby that has been identified, unfortunately, we're slowly moving some of these disease-modifying drugs down to that age group. We don't have them yet approved for use on someone that is just born, but we hope to be there in the next couple of years as there's more movement of these drugs in the clinic, and particularly as we learn more about the long-term effects, particularly when it comes to safety. Because one thing to keep in mind is that since these drugs are not a cure, they're not gene therapy, these are lifelong treatments, and we need to be reassured that these are drugs that can be taken for many decades. Now, what we have nowadays when it comes to just infants identified through newborn screening is fairly good standards of care across the different phenotypes that we see that allow us to keep these kids in good health until we can then make them amenable to treatment with any of the new modulator type treatments. But when it comes to, well, if we want to take a precision medicine approach with cell-based assays, it's about a 4-week turnover when it comes to, from getting the cells to be able to do the necessary assays.
That's great. That's really amazing. We have time for one more question, or one more answer. Just a short answer. Can you talk about the future in terms of gene therapy or tissue replacement therapy? I know that that's a big plus. There was a huge push with adenovirus a long time ago as gene therapy replacement, which had some promise. Can you give us an update on where that is now?
Yeah, well, as I mentioned early on, on our, what you can call it, roadmap towards treatment of CF, we had a 3-pronged approach, and gene therapy was a big one back in the 90s particularly. And, we're still trying to find the holy grail when it comes to gene therapy. We think that, disease-modifying regimens with small molecules are probably still going to be around as our main therapeutic tool for the long run. How to affect gene therapy and how to do correction at the tissue level, I think is going to remain a challenge. I don't know if Zach wants to make some comments along these lines also.
Yeah, and I think that while we are developing more drugs and identifying more drugs, the efforts in gene therapy continue. And some of those studies are happening here on campus at Stanford with Matt Porteous's lab and others. And so, yeah, we are excited about some of the advances, especially in CRISPR-related tools and other gene-modifying tools that have come out. And we're able to utilize those tools and using the assays that we've described to really test whether there are measurable and significant changes in CFTR function.
That's awesome. And do you think it's easier in the gut versus the lung?
Well, that's remains to be determined. I think that each has its own challenges with access. And whether you're talking about ex vivo gene correction or in vivo gene correction. And so I think that each one has its pros and cons, but I think that, you know, utilizing a multi-prong approach where we're not just focused on one set of cells and one assay, but rather a variety of different cell types and a multitude of assays, I think will help us get these complex answers faster and in a more complete way.
Wonderful. Well, I wanted to thank Dr. Sellers and Dr. Milla for an amazing demonstration of group science and precision medicine here at Stanford, previously funded and continually funded by the MCHRI. I want to thank everyone who joined today on our virtual seminar. I look forward to seeing you in 2 weeks with Mike Schneider talking about multi-omics and precision medicine. Anyway, thanks very much for joining us, and I'll now end this seminar. Thanks very much.